Good afternoon, Shellmark Advisory Service clients and friends, and thank you for joining us for our inaugural quarterly update webinar specifically for clients to hear our thoughts about the biggest events and just general trends that have affected the healthcare IT industry and the healthcare market over the previous quarter, as well as what we'll be looking to in the quarter ahead. This is our first one of these, and we're really looking forward to continuing this cycle every quarter and sharing exactly what we think is of note every 3 months. Be sure to submit your questions using the question dialog in the GoToMeeting control box. We will be addressing all questions at the end of the webinar, and if you could please include the analyst that you are addressing the question to, if it is addressed to someone specifically, that would be very much appreciated. Without further ado, we will now begin the quarter in review for Q1 2020, or that time when nothing went as planned.
Hello, everyone. This is John, the other John Moore. I'm the founder of Shellmark Research, and glad to have you here for this, as John put it, my son, the inaugural Q1, and we will be doing this quarterly. This is an exclusive service for clients that we started this year, and hopefully you'll get a lot of value from it. What we plan to do is, I'll do the lead off, and then each of the analysts will come in and give their own presentation from their own perspectives of what they're seeing in the markets that they track and follow within the healthcare IT space. The purpose is to bring you up to speed as to what we see as significant developments in the healthcare market and what that may pertain or imply to the broader health IT space. And also, the analysts will give you an early peek into whatever research they may have been doing in advance of the publication of a given report. So you kind of get an early sneak peek at some of the findings of those reports. I want to make mention that we will be sending out an email to everyone with a survey for this call, and would appreciate you filling that out. So as I said, this is our first one, and we want to continuously improve. We believe strongly in that, and we want to make each one even of higher value than the one previous for you, our clients. Okay, when I look at the quarter, I think, wow, yep, started with JPM. And I go to JPM every year, and it's really where healthcare and dollars come together. All the investment banks are there, all the big and small VC firms, the private firms. There is a lot of money flowing at JPM, which is held in San Francisco in early January. I saw lots of deal making happening there while I was there. Spoke to a lot of different firms in terms of what their interests were. Actually, it's kind of funny. I usually have most of a lot of firms asking me where should they be putting their money. I think there's a lot of money sitting on the sidelines, at least in January. There was a lot of money sitting on the sidelines in various asset classes that were looking to invest in healthcare because they saw healthcare as one promising area to add to their portfolio. Despite all the deal making and all the conversations I had, I was somewhat surprised that I really didn't hear anything terribly new. It was another approach at care management. It was another population health type thing. It was another analytics solution with some AI thrown in. But nothing that struck me as really significantly new that was going to change how we thought about healthcare and the delivery thereof. So that was JPM. And then, okay, there was a lot of noise around interoperability and the rules that were expected to drop any time in the first quarter. It even went so far as to the president being scheduled to speak at HIMSS this year. And of course, that was a clear signal that the rules would be dropped. He would be the one presenting the interoperability rules to the market. HIMSS was canceled. That was completely washed out. So, of course, this presentation was canceled. The rules were released the week of what would have been HIMSS 20 in early March, and that would have been the big story for all of us to talk about in Q1, or at least that's what everyone would be very interested in. It still is important. I don't want to detract from that, but COVID-19 came in and changed everything, including canceling that HIMSS event. And when I look at COVID-19 from my vantage point here, leading Shellmark Research, I mean, it came on us so fast and it's so expansive. It's touching every facet of healthcare that I really liken it to kind of healthcare's 9/11, much like 9/11 had an enormous impact on the travel industry and how we do travel, how do we secure travel in this country and as we travel to other countries. I think COVID-19 will have a similar far-reaching impact that is really at this time hard to measure and hard to completely ascertain, but COVID-19 will have a significant impact on how healthcare is delivered in the future. I have no doubt about that. So, when I look at COVID-19, okay, it was a real shock to the system. It exposed a lot of weaknesses to our existing system in terms of how healthcare is delivered in this country. As we found in our report that was published in January, the Path to Value was based on a series of focus groups we held with a number of healthcare providers across the country, large healthcare organizations, is that everything was extremely localized and that organizations had a difficult time kind of sharing best practices across their regions, across the nation. And I think this balkanization, this localization that we have in this country has led to our inability to provide a quick, coordinated response to COVID. Rather, we had a very poor coordination across the country. Everyone was trying to figure it out on their own, and the response has been slow. And now, we lead the world in the number of COVID cases. I think it was yesterday or the day before, we exceeded 400,000 cases in this country. And we're not done testing yet. It has stressed all aspects of healthcare. In talking to one of the major EHR ambulatory vendors, they said that in hard-hit areas, they're seeing through their system practice volume, visit volume, go down 50 to 60%. If you're an ambulatory practice, you really can't run a business at 50 to 60%. The cash is not coming in fast enough to meet payroll. There was also a story recently in Bloomberg about Envision, which was one of the largest leveraged buyouts in healthcare for healthcare services. I think it was around $7.9 billion that KKR paid to buy this large distributed, roughly it rolled up into about 168 ambulatory surgical centers. Because there's been, basically an order coming down from on high that all elective surgeries will be discontinued for the time being until this pandemic passes, they've seen a 65 to 75% cut in business across those 168 ASCs. And hospital systems, their bread and butter really is ED visits and elective surgeries. Those have been curtailed significantly, putting some very big economic stresses on them. And I'll go on to say that, you can take that story into long-term post-acute care, as well as IT companies as well, trying to service these healthcare providers. The only area I don't see too stressed, but we'll have to wait and see, are the payers. It remains to be determined how they're going to pay for all these COVID services that some say they're waiving or will not have co-pays for, et cetera. We don't know how much exactly that's going to cost, but we do know a typical COVID patient that's admitted into a hospital, their stay is about 2 weeks. The cash crunch that this is resulting in to everyone in this industry really calls into question, and I would also say the IT vendors, especially smaller ones or ones that operate on fairly thin margins, this is really going to call into question their viability long term. And I think once we start to climb out of the pandemic and things start to reverse, here we're going to see an enormous amount of merger and acquisition activity occur for those that are healthy enough to take advantage of the opportunities. There's going to be, so I would caution anyone that's out there, save some powder right now. We don't know how long this may last, but you're going to want to have some extra powder in the keg for when we come out of this, because there may be some opportunistic buys to make in terms of picking up some assets at reasonable price points. Lastly, I think we already had one stimulus bill passed for $2.2 billion, about 350 billion. No, it was more than that. There was this hundreds of billions of dollars are going to healthcare and healthcare systems. I believe the winners of that money primarily will be kind of the ASCs and the hospitals. I think smaller ambulatory practices may not see as much of that first round of stimulus as would be hoped, and I do worry about them. But much like we had with the stimulus back in 2008 under the Obama administration that led to the HITECH Act and the digitization of healthcare with the adoption of EHRs, my hope is that the federal government will see just how disconnected public health is from the rest of the healthcare system and those EHRs, and will institute a HITECH 2.0 to really kind of make up for all those things that we have today, that kind of balkanized system that I mentioned about earlier, the silos of data, the inability to provide a fast, coordinated response to something like a pandemic that we are seeing today. Now, I don't want to be all doom and gloom, but I do kind of want to mention what I see as kind of bright spots and dark spots. So I'll start with the dark spots. Hospitals, particularly those in rural areas, and many practices will close or are projected to close. We're already seeing a hit on personnel with Bureau of Labor Statistics report last week, reporting the most jobs lost were in healthcare, 43,000 jobs lost, and that was in just the ambulatory sector, almost all of it ambulatory. Secondly, one of the things I get really nervous about, just from my own experience, is that personal experience, is that oncology. Right now, since we're not doing any elective procedures, we're not bringing people in to check to see how their health is, or if there's something suspicious, doing an assessment of that. We are not finding out if anyone has emergent cancer. And as anyone knows, with cancer, you want to diagnose it early, quickly, and quickly start providing therapeutics to beat back the cancer. I'm a little bit worried as to this lag and how quickly we'll get back to doing those types of testing for suspected cancer patients. Lastly, a dark spot I see on the horizon is the recovery. How fast will the recovery be? Q2 obviously is a mess. I don't think Q3 is going to be too much better. Q4, the end of Q3 into Q4, it really, really depends on how well we as a nation are able to effectively respond should there be a second blossom of COVID in the traditional flu season, which is during that time when respiratory diseases proliferate. We're not out of the woods yet. So those are the dark spots. The bright spots, however, is that I'm incredibly impressed with the amazing resourcefulness of the healthcare system across all sectors in terms of what they're trying to do, what they're able to do, how they're able, and companies outside of healthcare chipping in on the PPE stuff, what have you, to make sure our healthcare workers are safe in providing care to these sick COVID patients. Also, for the IT vendors out there, I'm really, really impressed with the number of solutions that have come to the fore to address COVID. Early on, when this was just starting to get started, I think it was the week of HIMSS, that HIMSS would have been, I decided that we should set up a resources page to allow vendors to start describing what resources were they providing to the market to address COVID. I'm happy to report that as of this morning, I've made a count of them. There's 52 different companies on there with resources, and we still get submittals every day. So hats off to you. I'm impressed. Secondly, virtual care. This is here to stay. CMS has had a hospital without walls type of strategy all along. This is just basically gave it a rocket. And Teladoc in its recent call said that in the week of March 13th, visit volume went up 50% that week. When I was on a call with Kaiser Permanente, 95% of their ambulatory visits now are virtual. They've seen no drop in volume, unlike a lot of providers out there that have seen an extreme drop in volume because they don't have telehealth capabilities. KP really hasn't seen any. Lastly, the last example is Boston Children's. In talking to them, they said on any one day in the second half of March, they had more virtual visits than they had in all of 2019. I don't think that's going to change. I also think that lastly, around value-based care and population health, this may give some impetus for organizations to give a second look at that, where they're paid on a PMPM type of model versus a very transactional fee-for-service model. The fee-for-service model right now is really killing a lot of these healthcare providers. A more capitated type model or a value-based kind of contract, I think, would go a long ways towards providing greater stability for these organizations. So thank you very much. And with that, I will pass it on to the next person to speak, who is Alex.
Thank you, John. Good morning, everybody. Thanks for being here. I'm going to talk briefly about my upcoming report on provider-side payment integrity and revenue cycle tools. And then I'm going to dig in a bit more in depth into, as John was saying, what we call virtual care. We see that as more expansive than maybe the classic vision of telehealth as the remote appointment. It includes remote appointments, but it also includes asynchronous remote care, remote patient monitoring, elements of patient engagement and patient communication. I'm going to talk about the ways that COVID has changed how providers and vendors need to be thinking about deploying the technologies. Just to give you all a heads up, the slides are pretty dense. I'm not going to be addressing everything on each slide, but since you will be receiving the deck later, we wanted to make sure you had as much information as possible. If you have any questions, you can submit them into the webinar form, or if you want to discuss any of it more in depth, I'm always happy to talk. So first, I will cover the Payment Integrity and Revenue Cycle report. That report is scheduled for release in Q2. It focuses on technologies that are enabling and assisting in the provider side revenue cycle upstream and downstream in workflow. During the research, I've looked at what problems systems are trying to solve, how technology addresses those problems, and I've tried to look a little bit into the future to see what the use cases for those technologies will evolve into. As you can see from the slides, the main interest that systems have is in predictive and prescriptive technologies that for now are largely still in process. There are some examples of them, especially making suggestions, but in terms of full automation, they aren't a major place in the market. But these organizations also have significant interest in technologies that are more developed. RPA, for example, offers a lot of opportunity to relieve what are essentially manual decision tree processes that involve a lot of FTEs, even in a small hospital or a small system. Coding, the creation of claims, the appeals process, tracking and reconciliation. There are technologies that are well developed to address those needs, that are being deployed or ready for deployment, and that have a lot to offer. Providers are also very concerned about the path forward into value-based care and how tech they buy now, as they're in a more fee-for-service mindset, will support them in that transition. They want the ability to track and particularly project forward the effects of new workflows or process improvements on revenue across the breadth of their VBC contracts. The other area that obviously has gotten a lot of focus this quarter is in cost estimates and price transparency. There are really two different models within that market. You have general estimates based on procedure or activity groups, and then there are digital shopping models that approach in a similar way but offer definite prices and much more comparative functionality. Both of those are based on the FDA 300 procedure requirement, but they're really presenting to the market very differently. So in the next 1 to 3 years, I see RPA really taking root at scale, offering significant savings both from the improved processes that they enable and from the workforce relief. Some HCOs will be deploying some of that AI, ML technology, but I don't really see that maturing in the market until the 3 to 5 year mark. At that point, technologies that are currently in use, for example, in some asynchronous virtual care triage tools, are going to, I think, be more commonly deployed using ambient scribe technology, essentially to relieve a lot of physician documentation burden and integrate aspects of CAC and CDS when creating full documentation for billing and claims. Moving on to telehealth, what we saw at the beginning of this year, oddly enough, was the telehealth bubble starting to deflate. People have been talking about when telehealth was going to take off for a very long time. We've finally seen in the last couple of years telehealth begin to increase in scope and spread and adoption. And yet, despite that growth, the amount of usage it saw was still minute compared to the overall volume of in-person appointments. So, in my opinion, it was likely that the focus on face-to-face video telehealth, which has pretty significant failures to really deliver efficiencies in time for providers and cost to systems and to payers, was not going to last. I think we would have seen greater emphasis on asynchronous chat enabled potentially by AI systems, on RPM, and on areas like those that have more efficiencies that are proven and more proven care benefits. The other area where telehealth really struggled, especially in that face-to-face model, was in deployment. As I talk to healthcare systems and practices, these issues come up pretty frequently. They were major barriers not just to adoption, but in their attempts to drive provider confidence and grow provider and patient use. What we saw with many of the bigger announcements towards the end of 2019 and in the first quarter of 2020 has been focused on the primary care space, where Amazon, Cigna, and Humana have all offered and announced some form of virtual primary care, and then acquisitions and M&A within the virtual care space showed attempts to broaden beyond the strict virtual visit style into offering more capacity and more modalities of care. And then, as John said, everything changed. Over the course of March, a lot was done to expand access to virtual care, to make virtual care more of a viable business option for practices and systems, to increase the use of the breadth of virtual care options. It includes telehealth appointments, but also includes RPM and triage tools and communication. As I said, there's a lot here. I'm not going to read off each bullet, but you will get the slides and you will have this for reference. And even within that limited time frame of essentially a month, virtual care usage has skyrocketed, both for COVID-specific treatment, but also for other kinds of appointments, including primary care, behavioral health, and other appointment types, growing beyond what I would guess anybody expected we would see in the next 5 years in the normal course of business. As a result, systems which were prepared for this, which had systems in place, which understood how to use them, are doing fairly well with it. They are what we would put in the good box. One outpatient system in Massachusetts has transitioned almost all of its appointments to virtual care because they had invested significant time and training and capacity prior to this kicking off. Other systems were less well prepared, but had progressed somewhat down this path. And I see them as having a good chance of coming out of all of this, hopefully with a more mature outlook, more developed relationship with their technology, and ready to really start deploying virtual care at scale and looking at broader solutions. For smaller hospitals, for rural hospitals, practices that haven't done that work, in that last box, they are facing really significant challenges. The first wave of CARE Act payments are going to be structured around Medicare volume, which will leave systems and practices with large uninsured or Medicaid populations in a very difficult position. Organizations that were not prepared prior to March are in real trouble, and many of them are going to close. I think if everything had ended in April or even potentially, in May, most of this would revert and we wouldn't have seen a lot of these changes lasting. With the current predictions that it's going to, stretch into the late spring and early summer at least, I think we have a much better chance of retaining significant parts of this new regulatory system. Patients and providers are getting the chance to experience virtual care on both ends of the delivery interaction. They will see the benefits of it, and I think they will begin to expect it as a normal course of healthcare. And that means that it's essential that they begin planning, and vendors who support them begin planning how use of these systems will be maintained beyond the current crisis. Some of these new policies, for example, the HIPAA exceptions that OCR is allowing right now, are almost certainly not going to last, which means that practices and organizations that are using vendors currently offering non-HIPAA compliant solutions are going to be in a real bind, trying to redirect and reorient those efforts when those waivers expire. On the other hand, the new Medicare reimbursement, payment parity between in-person appointments and telehealth, allowing licensed providers to practice across state lines for Medicare, I see those as a lot more likely to last. Those were areas where momentum had already existed, significant momentum in a lot of states had already driven them in those directions. I think you will also see FDA waivers for some of the new uses of prior cleared technology. I think we'll see a pathway to keep those innovations in place as they're needed. As a result, I expect we'll see much more use of remote monitoring, innovative uses of technology, and that hospital without walls or hospital at home style technological deployment coming out of this. To talk more on that side of things about health in the community, I'm now going to hand it over to another analyst, Paul Nardone.
Thanks, Alex. As you said, I am Paul Nardone, an associate analyst on the Chilmark team. I've recently been performing some research on SDOH-centric IT solutions, and I'm in the middle of research on IT solutions that engage community resources. As John said, these segments of the industry also look dramatically different since the beginning of the quarter, so I'll be updating everyone today on how my findings have changed since the advent of COVID-19. Specifically, I'd like to highlight what the market looked like before the pandemic, the challenges faced by community resources during the pandemic, and what this means for the IT companies that want to support community partners. First, what did the health IT/community resources market look like before COVID-19? In short, mostly scattered, with small companies innovating in individual areas and with a few large players bringing the pieces together. Smaller vendors are pushing the boundaries in what's possible. The only issues are currently in scalability and what I've started to call the data intervention gap. Most current solutions are targeted at individual geographic areas, individual social determinants of health, or otherwise require huge amounts of effort to scale. For instance, some solutions are hand curating lists of community resources for individual health systems. This requires the vendor to contact, review, and enter into partnerships with effective community partners, then assist providers and community partners during the implementation process, then remain attentive to ensure that the enrolled partners meet standards for performance and contribute to program goals. The results on the small scale are doubtlessly impressive, as some health systems now manage extensive networks of community partners under their own banner and on their own digital platform. Yet, it's no surprise that few of these vendors have solved the puzzle of making those solutions scalable when it takes that much work on the small scale. Only a few groups have achieved those scalable solutions and begun to scale them up. Additionally, in my recent domain monitors, I talked about the gap between data and interventions. There's still a divide between the groups that are collecting information on communities, SDOH data, and the groups that are engaging those communities. It seems that the most mature data collection/analysis solutions are not being accessed or leveraged by the groups that need those analyses most. So second, the impact of COVID-19 on community resources. Community partners have been fighting on the less publicized front of the war on COVID, while providers and traditional healthcare entities have been leading the charge and claiming most of the headlines. Community partners have been dealing with their own struggles and sort of in the darkness beside them. The populations most commonly served by community partners are especially hard hit by the circumstances posed by the pandemic. So given the unequal effect that the disease has across socioeconomic classes. So demand for community partner services is quickly rising. Furthermore, the already unstably funded community partners are suffering from a severe lack of available short-term cash and labor as routine visits decline and volunteer work becomes scarce. The lack of resources available to community partners is mitigated somewhat by policies that have recently been enacted by the government. There's serious gaps in that safety net. For instance, community health centers can apply for grant funding to cover fixed costs, payroll, rent, utilities, but they actually have to compete with small businesses for loans if they need money for anything else in manner of equipment or supplies. I just posted a blog diving deeper into these struggles that different types of community partners are encountering. So check that out if you want a little bit more detail than what I've provided here. On a heartwarming note, though, there are new developments coming in almost daily where various organizations and individuals are committing resources and funding to helping these community partners and bolstering that safety net. For instance, Jeff Bezos, DiCaprio, Oprah, Apple, and a bunch of other notable celebrities have already put over $120 million into like America's Food Fund and other funds that target food banks and nutrition support programs. So charitable donations like these are filling some of the gaps, but even with the donations, some gaps remain. So third, what does this all mean for health IT and our solutions that engage community partners? We have these solutions, some of which show great promise. So what do we do with them to help? Unfortunately, given the stress that many community partners and provider groups are now under from treating the pandemic, rates of adoption of these new solutions will slow. A metaphor that's going to resonate with the skiers out there: our providers and community partners are experiencing the equivalent of careening down a difficult trail right now. It's too late to buy new skis or take a lesson. We just have to get down the hill as safe as we can. The large-scale solutions that we have are the new skis of the metaphor, and providing care during COVID is the trail. Once we get past the trail, we'll certainly recognize the value that those new skis would have provided us. So demand post-COVID for the new technology that these various vendors are offering in the market will certainly rise. However, now is not the time to push integration of most of these solutions. Dropping the metaphor, the march to value-based care and the capitation of Medicaid will only augment the post-COVID surge of interest. Unfortunately, though, many of the small companies that make up this market are in jeopardy due to the sales slowdown caused by COVID. If they were banking on landing a few large integrations or additional VC funding soon, then they're certainly at risk of having to shutter their doors. So what do we do? Right now, provide lightweight, low-cost, or free solutions that providers and community partners can take or leave as they so choose. Communication tools like Zoom, despite the issues that we've been seeing in the news with some of their offerings, search engines for social services like Aunt Bertha, and resource hubs like the ones that the NACHC has established are the sort of take it or leave it simple tools that can provide help right now. Additionally, facing symptom checker apps like the one provided by Buoy Health can alleviate the workload that providers face by allowing patients to self-screen for the disease and require no implementation on the part of providers. If anyone has any questions about these topics directly, feel free to reach out to me personally. I'd love to discuss anything related to social determinants of health, the engagement of community resources, COVID-centered or not. Now, Jody is going to talk about how we can leverage AI to combat the pandemic and how AI can help to bridge public health and IT.
Thanks, Paul, and hi, everyone, and good afternoon. So I've been covering AI for Chilmark Research, and in the last month, about a week before the period where HIMSS was going to take place, we released our report, The Promise of AI and Machine Learning in Healthcare, where I provided an overview of the primary companies involved in healthcare across the main verticals, from business operations, clinical decision support, population health management, patient-facing, and what the EHR providers are doing. And in that report, we discussed a number of other subtopics that ranged from bias and ethical issues in AI to data governance, some of the shortcomings of deep learning as a model used in machine learning, and where we think machine learning will go next technically. And then some other issues I've been covering, looking at the issue of explainability and creating more transparency in how the underlying models and algorithms work, so that both patients and providers can understand the tools that are being used, which is also part of informed consent, and looking at how this fits into the recent FDA guidelines. And going forward, we'll be looking at AI applications around coronavirus. Another area I'll be covering is this bridge between health IT and public health systems. I'm a public health guy by training, broad background, global health. So that's a very interesting area to cover in some of these linkages that the pandemic has exposed some major weaknesses in our health IT infrastructure. So as it pertains to AI and COVID, initial question we're asking as we move forward and watch this market, what's going to happen with AI offerings in the market currently, and how do they respond, and what utility do they provide to both frontline health workers and then more long-term and planners, and from everything from clinical to public health, that I think is going to be a very, very important aspect in AI research going forward, sort of bridging on a lot of the issues that Paul spoke about with social determinants and so forth. So we're really looking at what are the use cases that we think are going to be of greatest value in this pandemic context. And here we're looking at vulnerability mapping and risk stratification. We've seen a fair amount of tools, even in the current crisis, come out and attract quite a bit of interest already. Obviously, epidemiological modeling, and then from that, allocating resources and thinking about supply chains and an allocation of personnel, technical resources, and so forth. It'll be interesting to see how the tools developed pre-pandemic responded during the pandemic and what happens post-pandemic on that front. Also, we're looking at the issue of drug development and discovery, where there's a lot of clinical research being driven, coming out of the precision medicine world into both vaccine and drugs for COVID. And finally, bridging the precision medicine to precision public health, where AI could assume a very important role. So here in this issue of bridging public health and health IT, or as I just phrased it, moving to precision public health, that's a key area of interest because we think that the underlying value equation or economics of AI may shift as countries and states, cities go into lockdowns. The ability to do epidemiological surveillance and modeling, and then connecting that to your diagnostic screening, and this acquisition of data from your screening efforts will enable certain parts of the certain geographies to go back online in an economic way. So this investment in the underlying public health infrastructure, that value equation has shifted fundamentally as the costs of the pandemic have become so stark and apparent. And also learning from an international context how other countries address the pandemic in a much more robust way than the US has, and learning from how Taiwan, South Korea, Germany, for example, and this is still an ongoing story, so it's a very dynamic situation. And we can actually see how some of these countries took lessons from first round of SARS in 2003 and applied them appropriately in January, and therefore the economic and public health or the health impact of the pandemic have been far, far less. And then looking at the tools that can connect EHRs and hospital systems to this broader community and the analytics that can be provided hopefully by some AI tools to bring down some of the friction that's involved with bringing in social determinants and so forth. Can AI address any of those issues? And then finally, what are the emerging ethical issues as we do epidemiological surveillance that often requires, or there's some kind of trade-off with privacy and security, and or privacy and individual rights, and the ability to get economies going again. Different countries have taken different approaches, but are there models for surveillance, for example, using mobiles that also protect privacy, using differential privacy models and other types of community engagement tools that don't represent as great a threat to some of our democratic values and so forth? I think these are going to be very important questions as we move forward and deal with these tensions between the pandemic and the economy. And so that's my overview of AI and public health. And now we turn to Brian Murphy, who's going to discuss the recent interoperability rules.
Thank you, Jody. So I'm going to switch gears a little bit. I think I only make one glancing reference to the novel coronavirus, and I'm going to talk about these brand spanking new interoperability rules out of HHS. So they came out 1 month ago today to enormous fanfare, despite the looming crisis. They've been in gestation really since 2013 when something called the Jason Report came out, which called out many of the deficiencies in our healthcare system related to IT. But in any event, what these rules really do, if you kind of strip away their ornate complexity, is they establish what works out to be minimum requirements for organizations who hold data about patients. They will now need to kind of build and support in an ongoing way REST-style APIs built on the FHIR standard that are essentially outward-facing. These APIs are there primarily for the benefit of patients, but for other uses as well. So that the theme that kind of runs through all of this is that the feds were really trying to give patients better access and control to their data. And the expectation is that that better access is going to let patients engage a little bit more fully with the healthcare system, do better management of their own health, in much the same way that people engage with organizations across the wider economy. But it's really not just for patients. This kind of API first approach is really going to let all kinds of different developers build better applications for users and organizations across healthcare. There's two sets of rules here. The first is from CMS, and it primarily applies to Medicare regulated payers. As the slide indicates, it's got the main event here is this thing called a patient access API. It's an API that's based or modeled on the Blue Button program, the existing Blue Button program for Medicare fee-for-service beneficiaries. They're also going to have to provide more or less current provider directories. Members are going to have the ability to take their data and go to another plan. Part of this applies to hospitals. Hospitals are going to need to begin sending ADT notices to other providers for care coordination purposes. Second part of this is from ONC, and this is really the part that really got the most attention, in particular the information blocking part. There's two pieces to this. The first is some changes to the Certified Healthcare IT program, and it only applies to vendors who have products on that certified HIT product list. It includes the FHIR APIs for what they call electronic health information. And IT vendors are going to have to be able to support the ability for a patient to export their electronic health information so that they can go to another provider. And they're also going to have provide the ability for a provider to export all of the EHI for all of their patients so that they can go to another HIT vendor. The information blocking provisions, which was, the thing that this is probably most famous for, information blocking is against the law. But this rule lays out 7 fairly common sense, practical exception conditions where it's permissible for anybody who's covered by this rule to not honor a request. The phase-in for this happens over 36 months. There's a pretty strong expectation that that's going to be delayed. In fact, I was sort of half expecting to see an announcement from HHS announcing that the whole thing was going to be pushed back. The 36-month timeline, I think, is also in jeopardy. I wouldn't be shocking if that timeline got stretched out to more like 48 months. So those are kind of the bare facts of the regulations. Before I get into this slide right here to talk about how it's going to evolve, I just wanted to mention that this particular set of regulations basically sets up a kind of a technical framework for better interoperability. But it's very important to remember that most of the interoperability ills in the past had a lot less to do with technology and more to do with the economic interests of different payers. This does quite a bit from a technology standpoint, but addressing those fundamental economic issues is something that's going to happen in other parts of the healthcare system. All right, already mentioned the timeline's going to be delayed. One of the complaints or observations I've heard quite a bit since these things published is that how they're going to interact with HIPAA is still, to a lot of people, not clear. Before COVID-19, it was pretty much accepted among the health law and privacy communities that HIPAA was going to be probably replaced sooner rather than later by Congress. And, this COVID-19 situation certainly adds some fuel to that fire. A lot of organizations are going to be new to APIs as an access and integration tool. Many of them were not recipients of EHR incentive reform program payments, so they're under technology to begin with. Many of them have applications and databases that are fairly long in the tooth. Many of them have pretty well-established business relationships with other players in the healthcare system, and the idea of publishing an API to the wider world cuts very much against the grain. The certified HIT product list, which is arguably in a lot of ways the most important part of these rules, has a lot fewer products and vendor names than it did 7 years ago. I really feel like this set of rules is a lot of vendors are going to reevaluate their participation in that program. So unless provider customers really pressing the vendor, to keep the certification, I think a lot of them are going to start to think twice about it. So that will be happening over the next year or two. Updating a product to be compliant with this is something that most vendors have done, but it is a lift. So it wouldn't be shocking if we end up with primarily just EHR vendors on that list. The whole fee situation, fees are permissible under these rules. And the expectation is that an essentially market-based market for data will eventually evolve. The fees are going to be unsettled for quite some time. Under the HIPAA right of access, fees have generated a lot of controversy, a lot of litigation over, since 1996. The fees that third parties are going to have to pay to get access to patient data will probably go through a kind of an unsettled period, but given that particular negotiation is kind of a B2B type situation, I feel like that could eventually calm down fairly quickly as organizations get kind of more experience with each other. One particular time-related provision in this is that the validation process for a third-party app is something that, these regs are saying that process should be completed in 15 days. And if you look at the way EHR vendors typically validate third parties, it's on a much longer timeline. They can go months or more than a year. Really kind of depends. And in that process, the EHR vendor looks at a whole range of things that a 15-day window just would not let them do. So, I feel like in the end, there's going to have to be, eventually we're going to see some sort of third party stepping in and begin to be doing validation for these things. Payers as a group had extremely vocal objections to these rules, and it would not be shocking if we see some collection of payers begin to push back in the courts, which could delay the implementation of this. So, wrapping up here, this does kind of set the industry up for this idea that the EHR itself is kind of a platform around which either the EHR vendor, customers, or third parties begin to develop applications that do different things. The EHR, is the data persistence engine. It does all the workflow orchestration, but it's really up to other developers to kind of fill in the blanks and make these things more productive for more different kinds of users. I have to recognize that not all EHR vendors are necessarily on board with this, but this certainly sets the stage. The other thing that I think EHR vendors are in particular going to want to really get their existing validation programs are going to have to be revisited. The user-facing app stores, as it's done in the consumer world, there will be need for more scrutiny of what's happening with these third-party developers. So with that, I know we've gone a little bit long. I'm going to turn it back over to John.
So thank you everyone for attending. We are now going to switch over to the Q&A portion of this and field some questions from the audience. The first one that we have for Alex is, during your talk, you did mostly speak about telehealth as it relates to virtual care, but what is the future for remote patient monitoring, and will COVID-19 accelerate this market as well?
Yeah, that's a very good question. COVID is going to significantly impact that. The biggest single element affecting that are the FDA waivers that were issued on the 20th. Those opened up a lot of opportunities to modify and redeploy hospital scale and other FDA cleared technology into the home, to integrate them into a wireless or remote service, to add new functionality as it relates to monitoring and to reporting, to modify AI and other algorithmic elements of that technology. And as I said, I think those are all going to outlast the current state of emergency and really have a major impact. Broadly, I think technology in general is making really interesting progressions in RPM, in the ability to deploy more broadly functional monitoring technology, to have infrastructure and networks that support it. We see that some in the CARES Act with the supplement for building out high-speed internet access across communities and in rural and low-income areas. And that's an essential part of supporting RPM as a technological platform. My view of virtual health, and the reason we call it virtual care as opposed to sticking to the term telehealth, is that RPM is an essential part of it. You really can't do good virtual care without substantial ability to check in, to monitor, to see how people are doing. And you get the best results clinically from having that more granular monitoring and that better transparency into patient behavior and activity in the home and outside the office. So my view is that RPM is a major component of what we're going to see as successful virtual care platforms going forward. And a large chunk of that is going to be supported or driven by what's currently happening with COVID.
Thank you, Alex. Great answer. So the next question that we have is for Paul. How do you see social determinants of health and solutions to support development or change post-COVID-19? Are there certain aspects of these solutions that will become critical or must-haves that we do not have in place today?
So I'm taking this as like, what is COVID-19 going to sort of show in these solutions as lacking, right? I think that's
exactly, yes, I believe that is.
I think that's the essence of the question. So I think that what had been lacking beforehand and what's now being like made abundantly clear is that we don't have good sort of workflow integration between what's going on in our community resources and what's going on in our like provider systems. So a lot of times we'll have our providers who are aware loosely of some social determinant related need and might be somewhat aware that there are community partners available who are able to address that need in their patient, but they don't have any sort of workflow means to get connected and understand how their patient's utilizing this partner, even if they are connected. So there's this big gap between the providers and like the community partners and as far as the actual workflow of it. And I think that's going to be one big area of improvement that we're only now starting to see some people kind of do on the small scale, like I mentioned in my piece. I think the other bit that I mentioned as far as areas where we need to improve are if more of the large, because there are some companies, some like big data crunching companies that are doing great work analyzing huge reams of data related to social determinants of health. And a lot of that analytical capacity isn't yet being leveraged, and instead provider groups are opting to do a lot of it on their own. So they're trying to send out their own questionnaires and make their own models for addressing social determinants of health data when we already kind of have a ton of it available just in different industries or in different organizations. And so once more partnerships are made between these really advanced data analytics companies and the providers, who hopefully soon will have community partners integrated into their workflows, like we're going to start seeing really powerful solutions coming together on a large scale.
Okay, thank you so much for that, Paul. At this point, we have come to the top, a little bit over the top of the hour. And if anyone has any additional questions, we will be sharing the slides with each individual analyst's contact information at the beginning of their segment, so you can reach out to them directly. Or you can contact me at john3@chilmarkresearch.com in order to schedule an analyst inquiry with anyone from our team. Thank you again for joining us today, and we hope you found this helpful, and we'll be joining us again in 3 months' time when we do our next one of these.
In closing, I would just like to say to everyone, be well, stay safe, keep your distance.
We'll get through this together.
We will indeed. We will get through this.